solid tumors and 10 days in hematologic malignancies. So these are the subset of patients actually who present mainly in an oncocritical care ICU. So coming to these patients are basically immunocompromised. If we take the CDC guidelines about immunocompromise, it says that any person should be considered immunocompromised if he or she is undergoing an active treatment for solid tumor and hematologic malignancies. More importantly, this part of the domain, active treatment with high dose corticosteroids, alkylating agents, antimetabolites, transplant related immunosuppressive drugs and cancer chemotherapeutic drugs are classified as severely immunosuppressed patients. So all 100% patients of my ICU belong to this category. So this is a category in which every patient is immunocompromised. So time is a luxury for us. So coming to the topic, invasive fungal infection, as we all know sitting over here, okay, it has been divided into proven invasive fungal disease, probable and possible. In proven cases, we have fungal element demonstration in the tissue, and in probable, we have lots of factors, clinical features, biochemistry is going up, and in possible, IFD, we have demonstration of host factor and clinical features which are still in suspicion. So the etiology, as we say, that every patient in this group of oncocritical care is an immunocompromised patient. They have broken mucosal barriers, and fungi are obviously opportunistic. So are fungal infection a real problem in Indian scenarios in ICU? Obviously, especially in oncocritical care, because these patients are immunocompromised and it has a high rate of incidence than normal ICUs that we get with these fungemic patients. And it leads to actually a high rate of mortality and morbidity, and because first it is difficult to diagnose, and second, once it seeds in, it gets difficult to treat because of the new kind of resistance patterns that are coming in fungi also. So India being at high risk for invasive fungal infections because of overuse of antibiotics and antimicrobial drugs, diverse climatic conditions, very few good diagnostic mycology labs, and lack of Indian credible data on the incidence of invasive fungal infection. So if we compare about our trends versus the Western trends in the past few years, probably the past 10 years, so in India, this Candida has been the third most common nosocomial infection in ICUs, and the difference where it lies, it's Candida non-albicans variety are getting more and more common than Candida albicans variety. Among non-albicans variety, tropicalis is being reported more than albicans, whereas in Western countries, albicans variety is the more common variety. So this shows right from the 2012 paradigm of time for the past 10 years, where it was first reported that the trends of Candida in India are changing, and we are shifting to a variety of non-albican Candidas. So this again shows the same thing. So Candida being the most common fungal infection in ICU, and non-albicals being the major contributor to it, we need to consider our drugs or antifungals according to that. This is another study by Arun Alok sir conducted at 2015, which again showed that the ICU-acquired candidemia were happening even in cases of non-neutropenic patients, and median duration of onset was 8 days, and tropicalis was the most commonly found variety. And in a cancer ICU, the letter in bold, that among types of surgery, abdominal surgery is considered as a leading risk factor for candidemia. So maximum patients in oncocritical care have already undergone some hemicolectomy or a HIPEC or something. So the clinical suspicion for these patients have to be really high. If we delay the treatment in any patient with suspected fungal sepsis, we lose the patient because time is a luxury for us. So all the risk factors are actually in 80% patients of our ICUs. Greater than 3 antibiotics for more days, antibiotics used for more than 4 days, CVCs, TPNs, neutropenia, immunosuppression as we talked about, and Candida colonization. So all these things make candidemia very common in oncocritical care scenario. Among the treatment, actually the treatment had been developed into prophylaxis, empirical and preemptive. So according to the different there are different schools of thoughts, but ultimately the best judge is the clinical condition of the patient. If the patient is rapidly deteriorating, then we obviously go with the treatment. So how has antifungal therapy evolved over time? So first it was naturally the azoles mainly, then echinocandins came in, which actually acts on the beta glucans in the cell wall. And why echinocandins? Because they had been proved to be definite than azoles in cases, in terms of side effects and the patient mortalities. Now, recently the Indian antimicrobial prescription guidelines have come up in critically ill patient, immunocompromised patients, especially for neutropenic patients. It says that wherever a patient is having a persistent shock or respiratory distress or persistent fever more than 3 days, we should escalate to an antifungal, and probably the choice in that case would be caspofungin, according to this study and the data for the Indian scenarios. And we all know all the guidelines, actually the IDSA guidelines, the ASCO guidelines, obviously recommend echinocandins in hemodynamically unstable patients. So in choosing the right antifungal for ICU patients, we actually need to consider these data, because parapsilosis is something that echinocandins is not going to cover. Among most other candidas, echinocandins have a very wonderful coverage. Among the molds, if we talk about aspergillus, the data about other echinocandins other than caspofungin and that like anidula and micafungin, there are no much data about aspergillus. Whereas caspofungin can even be considered in a patient as a salvage therapy for aspergillosis when he is having a lot of side effects to voriconazoles and all. So this is what it says, that even caspofungin can be considered after the failure of conventional therapy in patients already on voriconazole. So now this is a comparative study between various echinocandins, which shows caspofungin has definitely got an activity against candida and aspergillus and should be the first choice in patients with invasive aspergillosis and febrile neutropenia patients. And no dose adjustments are usually needed in renal failure, but obviously nothing is perfect. There are flip sides. Caspofungin needs dosage adjustment in hepatic insufficiency at Child-Pugh score C, but not for typical transaminitis in critical care. Caspofungin is well tolerated over there. Hepatotoxicity is more in case of, in combination with cyclosporin. So we need to consider the chemotherapy regimen over here. It definitely has a very poor penetration in the eye, CNS and urine, and it is not active against zygomycosis and candida parapsilosis. So that will be all. So caspofungin, being an echinocandin, is like a light in the darkness in our oncocritical care ICUs when a patient's fever or sepsis is not responding. So any questions, please?
What is the antifungal culture in your hospital? Is it all, there are no azole sensitivity, or it is all mostly echinocandin? What is your...
Actually, in our hospital at Chittaranjan National Cancer Institute, we have been blessed with a MALDI-TOF machine. So in that part, the identification is really rapid. Rate of positivity is also low, but it is actually azole sensitive. Maximum cases are azole sensitive. But the problem with these patients are, whenever they are getting shifted from wards from hematology or after surgery, maximum 80% of these patients are hemodynamically unstable. So fluclonazole, considering fluclonazole at that stage, is actually not an option for me maximum times. Maintenance after de-escalation, if it improves after that, we go for azoles. That is how we go for it. Initial choice, we just see, initial choice actually depends on the patient. Suppose a patient is hemodynamically unstable, a lot of liver handling and hepatectomy has gone on after a Whipple's. So obviously I'll try not to use Caspo because I'm expecting a liver dysfunction. In other patients who not much of liver handling, a hemicolectomy has gone, or in a hematology patients, I'll obviously jolly go with caspofungin and all. Micafungin also, well, just because.
What's the hepatic safety of other two kind of candidates?
Other two are comparatively safer than caspofungin, actually.
So, you prefer anidula or mica over caspo in that?
Exactly. That is what we are talking about.
What about choosing the investigation of choice in case of suspected aspergillus?
Actually,
repeated
huh.
on a regular basis do send beta glucan or galactomannan
Uh,
or aspergillus PCR for those patients?
no, aspergillus.
What
Huh.
are the choices?
The choices actually it depends on the subset of patients. Suppose the patient we have on a background of CA lung even or a background of any other CA. He comes with us with respiratory distress. We are thinking that for a preemptive therapy. The antibiotics for 2 days are not responding, probably is going to have something else. We go for initially for an imaging because X-rays won't give much information and a galactomannan. So seeing that, we try to go for voriconazole or caspofungin, whatever. So if it does not respond, then obviously we go for a BAL and serial galactomannans. So that is how we work.
One thing is there, whenever we send beta D-glucan or galactomannan, we are thinking of the piperacillin tazobactam, the patient is on or not, because there is a very high false positivity rate in those cases. Then there is any other option of sending any other investigation for specific aspergillus infection?
No, actually, we have the facility of PCR over there. So that is why things get easier for us. Okay, okay.
Thank you.
Thank you.
Thank you, sir.